Right, I think we can start. So, good morning, everyone. I welcome you all to this very enlightening session. As we all know, this is the world of advanced technology. There's AI and there is a lot of other technologies, but the problem is that Indian healthcare is much behind other countries in terms of digital health. And the government is making all of its biggest efforts is the Ayushman Bharat Digital Mission to make even the small and medium clinics get acquainted and get access to digital health. So we have with us a very special speaker. She is the lead for ABDM Adoption in private healthcare networks. Yes, and I'll hand over to you, ma'am, to further introduce you and start the session. Thank you.
Thank you, Mridla, for giving this opportunity. I'll just take a shot. Yes. Yeah. Uh, Hope my screen is visible and I'm also visible to everyone.
Yes.
Yeah. Good morning, everyone. And yes, thank you, THC and Dr. Mridla, for giving this opportunity to come on this platform and connect with you all and, for giving you valuable time for this webinar. Thank you so much. Yeah. Today, the overall objective of this session that we want to, come through this platform that, NHA, that is National Health Authority, has come first time with a HMIS solution, which is specifically focused for the small and medium private healthcare sector. And with that understanding, we have just tried to cover that, what is all about a basic understanding to the participants who are not much aware of ABDM and had some myths towards that will be covered under the overview of the ABDM and, its benefit, that what is the benefit that you, if you adopt ABDM ecosystem towards your, doctor, medical professionals as well as to your citizen to whom we are trying to give a quality services. That Mridla was mentioning in the beginning that, where when compared to the world, we are still behind to reach those targets. Then next, we will be covering that. How eSushrut clinic, we have many HMI solutions, and we know that how in this AI world, what are the effective, tools that we have which can be effectively used. But with HMIS, this eSushrut clinic, the whole objective is having that trust and the myths which is there in terms of, sharing of data and exchange of the data related to medical records, and how this will help to overcome those challenges. So that we will cover in under the eSushrut clinic brief introduction. And similar to that, we have already implemented from last 2 years and clinical decision support system, which was developed by AIMS Delhi, and it has been successfully integrated with, HMIS, who are enabled with ABDM ecosystem, and many of them are already adopted CDSS. And the what from last 2 years, what is the impact that CDSS has created? That also we will share it with you. And at the last, we will have sure Q&A session, and we will give maximum space to the Q&A session before closing this call. And at the last, we request everyone to be part of the, 6 sessions that, we will be looking for the support that we want from each one of you who are there today in this webinar. So this is all about me. I am basically having a good experience in healthcare, digital healthcare initiatives, and I am closely working with central ministry and state governments, and currently leading for the ABDM adoptions focused upon the private sector adoption, right? And in private sector, if I say, I would like to highlight that we have two sectors divided, like, a big chains of hospitals wherein, we target like Fortis, Apollo, and many more. But in ABDM, we understand that although we know these big names to be, come into when we think of healthcare, hospital, or anything, but coming to the second point, the maximum coverage which we have in India, which is more than 60% in all over India, is the small and medium. So we have a dedicated team who focus upon the small sector, small domain of healthcare facilities, as well as labs and the pharmacy, who gives the basic 90% of health coverage to the middle, citizens when they come for the healthcare services. So our team, I am leading with the fact that, we are focused to have an ABDM adoption for the small and medium healthcare providers and the tech providers for that. So this is all about my experience in short. Now, uh, I would like to just mention few things. I will request everyone to park their questions till we, finishes our basic understanding that what we want to share with you. And at the last, we will have half of the session dedicated only for a Q&A related to ABDM as well as for the eSushrut clinic. Right. So, as I mentioned, that we just wanted to have a brief understanding that what ABDM is and why it is. For to those who are not much aware of this, what ABDM is and the myths that we have it. So ABDM aims basically to have a dedicated backbone of healthcare. The way we think now, we have UPI in our hands for any medical, for sorry, any financial transaction. The same way now we will have ABDM ecosystem for any health related transaction that we want to have it, right? So that is the backbone which is necessary to support the integrated digital health infrastructure for our country. When I say integrated, I mean to say that whatever hospital where you are, wherever the labs you are going for your test, or wherever we are there for the medical prescription based on we take the medicines, all are integrated on a common platform which is based upon standard set of policies and technology, which is very secure and trust on with a standard within proper SOPs being defined to develop that ecosystem. So the policies on which this entire ecosystem has been built is considering the privacy and security of the citizen, of having their data being secured wherever it has been initially generated. Like if it is at a hospital, the data is secured with the hospital. If it has been generated at the labs, the lab reports, it is secured at the lab. So based on the consent only, the data is being exchanged to any health providers of the citizen when the citizen give it. So the entire design of this has been based upon standard policies related to your privacy and security of the data of the patient as well as of the hospitals and the labs. User, from the user end perspective, we say anyone who is part of the ecosystem is eligible to adopt this. And of course, when I say it's volunteer participation, is basically the advantages and the benefits for which we want everyone to go for the adoption. But yes, just like initially when we started with Aadhaar, it wasn't volunteer, but now Aadhaar is compulsory wherever we go. In fact, for our kids' admission also, we need our Aadhaar. In the same way, the future is not that far that when our ID will also be asked for any hospitalization or your prescription being generated, that the patient should have its ABA ID unique identification. So, adding to that, this we have already covered much of its journey. That as on date we have around 80 crore of ABHA IDs being generated, and most of our population, half of the population, is now having an unique identification of health record, that is ABHA ID. Now, coming to the technology part, it's a single source of truth. Yes, we have a dedicated platform wherein all the health facilities and the doctors are being verified and stored with a unique identification that is known as health professional ID and health facility IDs. When I say this, we have a dedicated platform wherein every hospitals and the doctors are being registered and verified with the source of the data, where about their registration, their qualification, and everything. Like suppose a citizen goes and he gets a first thought whether it's a genuine or not. So if you have the NHP ID, you have been verified that. So all that source of data, wherever the patient goes anywhere, he has the fact that if it is an ABDM ecosystem which is enabled, and that clinic is having that HMIS solution, the doctor is verified by us. Now, when I say it's a federated architecture with open API interoperability, it means that it's open to everyone. It's just like UPI transaction we do for the bank. Any bank can be the part of the UPI and do its transactions through one bank, any another bank, rather than restricted to a particular bank. In short, this is an example that the way UPI has explored to such a high level, in the same way, with the same architecture and the support of the standard protocol, help us to grow this ABDM ecosystem in the same way, the way an UPI has been now taken up. So what are the core building blocks on which this entire policy and technology has been integrated together to build this ABDM ecosystem? The core building block includes, first I explained here what is health facility or the health professional registry. It's a single suit of truth which is being integrated as a core building block. ABHA ID, I mentioned that each citizen will have its unique identification number wherein all its health record will be stored. When I say UHI, that is Unified Health Interface, it means that a single truth of source is a platform wherein any doctor or facility can register itself as part of this ecosystem, and any patient can find out what is the nearest labs or the doctor which is available for the services, specifically focused upon the teleconsultation point of view. Just like we go for a search at Practo or something and we get a verified. In the same way, this is a government supported platform with UHI interface wherein the patients can directly search the verified source of professionals and the facility to get the services in healthcare. ABHA app is just like a mobile app, the way you have your transactions being monitored at of your banking in a mobile app, like iMobile apps we usually see it. In the same way, the patients will have a simple mobile app, that is ABHA app, enabled by ABDM, and wherein patients can have their entire set of records being digitally saved, and wherever they go for any consultation to the doctor, instead of carrying a paper in their hand, they can go and visit with just a mobile phone that doctor asks, and they can share it. I'll just show this entire flow, that how in my next slide, that how this entire circle of patient visits this clinic or the hospital, and how this journey goes. Now, when till now I have spoken about UPI and UPI and why we are moving to the today towards this entire shift of the way we shifted from uh, money transaction. When you go to a grocery, you used to give cash, but now we give our show a QR code and scan it, and that's over. In the same way, how come this ABDM shift is there? Now, ABDM ecosystem is enabling all the small healthcare workers to a small healthcare clinics, a general practitioner. If I say a single doctor who owns a single private clinic, can also be a part of the ecosystem, and their generated prescription and the reports or diagnosis which they ask for the citizen, they can go to any lab. That will be integrated a common ecosystem which will help them to just transact you know their reports, their prescription for any medication which they wanted on a click of few buttons. That is the basic benefit of this, which is explained on the left side of my screen, that how everything is being come to a single point, the way we have on the right side, that all your bank accounts are connected to a mobile phone through a UPI system. So basically, this entire revolution, I can say, the way we slowly moved, digital banking, in the same way we are now moving towards health record or any, services related to healthcare being so easily, given to the tech providers as well as to the doctors, who are basically aim to focus upon the quality services to our patients. So this is the reason that we are targeting to give the best services to, at the end objective is to give a quality care services to the patients. That we have to shift our mind. Initially there was a force behind us in 2020 that which made everyone to move towards digital transactions, but same way the same force will come one day wherein the entire shift of digital healthcare, when we everyone is talking and forcing going moving towards that. So we have already initiated, we have passed on certain journey on it, but at the you know when we go at the touch points of rural areas, it is still lagging. Even in urban also, although we are at a high tech, but still when it comes to adoption, somewhere we are lagging, and there are myths which need to be sorted out. Of course, we are here for that. So this is the short journey that we tried to put up on a single slide, that when a patient comes to a consultation to the doctor, how easy his journey can be. That see, normally when you go, you have to be for 5 to 10 minutes to have your registration done at the desk at any clinic as well. But if it is a completely now it is a QR code based system, wherein wherever the patient is and your clinic is having a QR code and online access, he can just take the QR code, scan, and give the registration and inform the clinic that I'm going to come. So this is simple QR code. No need to go directly to the clinic. You can have a QR code appointment system. Doctors now knows that, so at so and so time my patient is going to come. Then doctor, before it's, the patient comes, doctor can see the history as well, that, I would like to have, if you have come for this appointment, I would like to have certain set of health records being, for me to understand your history. That patient will share is based on the consent request raised by the doctor through the PHR app. As I mentioned, it's an ABHA app. And then doctor can view those records of the patient. Patient will give the consent will be granted, and then doctor can easily view the records. And like this, the same journey starts with, a single patient comes to a clinic and the cycle rotates, it goes to another one, same cycle will be generated. So this is how the entire journey, you can see there is nothing paper in its hand, just it's walk in, and, with the projection that I'm going to come, and the data will be shared, and the doctor will able to save its record to particular abha id, wherein no paper is required for him to hand over it, unless and until there is a change in mindset that, yes, the awareness to the citizen, my patient comes, yes, they should be aware of this. We have to just put certain elements, like IC material, for, keeping the patient aware that why we are asking your record. So that will help them to build their trust towards the clinic as well, that yes, whatever they are asking, there is a reason behind it, and what benefit they will get. Next, so this was all about, ABDM adoption, and what is the need of coming towards this shift of, being digital. Now, what contribution eSushrut clinic will make into this is that, the way we say normally, 2 minutes Maggie, I'll say, in the same way now, being on an ABDM enabled ecosystem for a short, for a, small clinics is now simple as 5 minutes onboarding into an ABDM ecosystem. With this, I just like to highlight two three things. Currently, we have in eSushrut clinic is just a simple HMIS, which is targeted for, small and medium healthcare practitioner. Currently, we have the, OP module, which we say OPD part, that outpatients patients are, digitally their records are being saved or diagnosed, and prescription are being issued. Soon we will be coming up with the lab system as well, wherein, large chains of lab will also be having the same kind of, digital reports and sharing of the record, rather than, just having their WhatsApp. I know everybody is very now convenient with their record. Your reports will be there in your WhatsApp number directly. But, when it comes to, to verify the history of your lab records, you have to search and scroll, where is my so and so record, right? Instead of that, your all records will be given to will be available on the WhatsApp as well as to your PHR app, so that you need not search it when you want it, where it is, like 1 year 2 years back, your records, your lab reports. So that is one of the benefit that we will be coming, and it is so simple that, the basic digitization which is required at the lab, at the hospital or the clinic part, is now at come with a very very nominal cost when compared to a market price, I will say. Just at currently it is, right now it is free of cost to all the, because it's a launch of this application. Thereafter, there will be certain prices, like, hardly 300 rupees per registration. And when I say 300, it's just a base. When compared to the other private clinic practitioners, we this is very nominal or subsidized rate given by, Ministry of Health, that, to just to focus upon ABDM adoption in small and medium healthcare practitioners, because we understand there is a huge constraint of financials, being thought when it comes to digitization. So this was the point that, why we are here, with most of the thoughts written on the slides, that AB eSushrut clinic is, first steps towards your digital prescription. When your patient comes, it will have its digital prescription. It can book, your doctor slots as per the availability of the doctor's calendar. Doctors will have their own doctor desk, and then they will have their what to say, the planned session of, for the entire month based on their availability of the schedule. Now, when I say that, with the 5 minutes enablement with the eSushrut clinic, the whole objective is that anyone who is coming on boarding the eSushrut clinic should have a verified HPR ID, that is health professional ID, with a single HPR ID or the verified mobile number which is registered against your HPR ID will be used to log in and onboard the eSushrut Clinic application, or they can say a subscribe to eSushrut application, wherein you have to just enter your HPID with no cost to that, and register yourself, add your facility ID that I mentioned as HFR in the initial slides. That health facility register will have your HFID, and that HFID will automatically be linked with the HMIS, that is eSushrut Clinic, and you're ready to move with your clinic with an ABDM ecosystem. Our team has already initiated this drive, and the whole point is that this drive has already led to approximately 100 practitioners have onboarded the eSushrut Clinic, and there are transactions have already been initiated. Around 100 plus records with prescription and registration of the patient have been initiated. So the whole point was that, as I explained in my initial slides, that what are the core building blocks, that is HFR, the HPR part, the ABHA ID. All this there is there with you in 5 minutes. That you can just need to have your verified health professional ID from the NHPR portal. With that ID, you have to just subscribe yourself on eSushrut Clinic. We will share you all the links that they can share to the concerns, and you can ask them to inform about this one of the benefit that is coming free of cost from National Health Authority to onboard this application. So as you can see, some of the features that AIMS has developed, that is clinical distancing has already been integrated, and speech to text EMR is there for the practitioners, those who are feel sometimes writing on pen is much easier. So we have initially started with speech to text. They can directly speak, and ask them, the EMR will be generated. And further to that, this application will have the basic four initial modules for next few months. After that, we will have the lab management system as well. So when I say with the OPD part, the doctor prescriptions, and the nursing desk is available. The nursing desk will enter the basic vitals of the patients at the time of registration before moving on to the doctor's desk, and the doctor's desk can take those vitals and have the inputs and give it to CDSS, and CDSS will give within seconds then what are the best recommendation to the doctor, and doctor can take a choice that yes, these are the basic, not giving much effort on it. Entire is considering the history of the vitals entered by the nursing direct will be communicated to CDSS, and CDSS will give its best recommendation directly from the AIMS Delhi doctors, that these are the recommendation to this patient, and that can easily be picked up by the clinical doctor and added to the prescription. No need to add any, write any medication, medicines number, doses. All this will be automatic, has already been integrated, and that will be fetched to the prescription part of the patient. Next, that is the basic need, that billing and the MIS part has been integrated into this application. So to kickstart the journey of ABDM adoption, or I can say a digital journey for the clinician, this is the basic need, that when a patient comes, he should be registered with a unique ID, and then it should not have any challenges of having the appointment with the doctor. That is already planned and scheduled in the application. You can just see that so and so doctor is available on so and so time, basically matching to the patient's needs, and then they can book with the doctor's appointment and come directly to the clinic, have it, and at the end they will have their prescriptions on their PHR app. So we just wanted to kickstart the journey of small and medium sector, so that the adoption part initiates, and of course when the benefits are being observed, they will slowly move on the digital part. So this was the objective, that when I say it enables you within 5 minutes, that yes, the journey actually starts. Only thing is that we have to move our towards that, we have to do something different than when compared to the regular routine. So these are some of the benefits that eSushrut Clinic is having, and directly supported by National Health Authority, that is integrated with EHR with ABDM compliant solutions, and it's completely a web-based application, that is a cloud-based scalable architecture. And yes, we have started with that initially for each and every health professional ID, you can have, for every facility you can have your 5 to 6 users free of cost towards your clinic, because we have understood that for small single practitioner, maximum 3 to 4 user IDs are required to run the entire clinic. Like suppose the user is having one billing desk, the registration desk, the OPD part. So if they have two or more doctors working in a single clinic, they can have 2 to 3 HP IDs being registered to the respective facility and start the journey. So, as I mentioned, clinical decision support system is already integrated. Soon we will be having an analytical dashboard as well, which will give the doctors that how many patients, which category of patients, how many ABA based registrations have been taken up. And then, as I mentioned, the way we have our Aadhaar unique identification, one of the core requirement of ABA ID is already there with us. Now, why we have basically taken up this session, that uh, we are here, we are at ABDM and NHA, but considering some of the factors that half of the six, as I mentioned, that 60% of healthcare services are being given only by the small and medium healthcare practitioners, wherein 90% of health hospital beds are covered under this session. And coming to the revenue part, you can see here we have done a second research and we have identified that 65 to 75 percent of revenues which is there in healthcare is coming from small and medium itself, and there is a targeted well-known growth by financial year 2027. Second, some of the practitioners that we wanted to say, that as mentioned, that is specifically focused upon single practitioner. We have considered some of the search, and we have identified that around 2 lakhs of such professionals are there, wherein most of us know that well-known doctors have their own clinics as well. So suppose if I am there at a big hospital and my same doctor is there in the evening available second slot, so the doctor can come and the entire journey can be easily linked, that what wherever whichever location the a patient comes to have the consultation with the doctor, it is being digitally integrated there, all the records for giving a quality service to the patient. Next, this the whole objective of bringing this figures on this single slide is that although we know that when it comes to hospitals become big names in our mind, but actual coverage which is there at the ground is by the small and medium hospitals only. We can see here the numbers. In the same way, diagnostic labs are also one of the crucial parts to come to the adoption, that more than 1 lakh of labs are there which still need to be onboarded into ABDM ecosystem. Vice versa, pharmacy, we know pharmacy is now growing at a watch, like every I can say a state is having its pharmacy shop, that you can see here, approximately 7 lakhs pharmacy shops needs to be onboarded with ABDM ecosystem. And these are some of the numbers that we have taken up, and we want to emphasize on that wherever the doctor is, wherever your patient is, we have to come to a single platform of ABDM ecosystem to digitize the entire journey. Now, this is one of the, in the initial slides, I mentioned that CDSS is one of the best practices that was adopted by HMIS and ABDM enable HMIS, and we can see the benefit of CDSS has already given an impact, that 2 lakh plus recommendation has been given, and the HMIS providers who are there, in which within I can say few years, around 14 plus have already integrated, and many are in process of integrate the CDSS into their HMIS, because they can see that benefit of integrating CDSS help them while giving us services to the patients, that yes, the source of recommendation that we have is from the best of its doctors in the world. So that is what, in the same way, when we say eSushrut clinic is also driving the same force, that we want the adoption of digital healthcare system with a simple clinic, that whenever doctor is having, it's a simple room based clinic is also having an digital system wherein the recommendation from AIMS is directly coming to him. So that is whole objective of bringing this slide over here, that yes, the change happens even starts with a simple one doctor clinic. So now overall my point of view to come here is that we want your support to go ahead with adoption of eSushrut clinic, in terms of keeping your sharing your awareness to other practitioners with the doctors, that this has come with at a very subsidized, and initially it is free of cost, and any change in plan will obviously be shared, but we want active participation from each and every one of us, and we are conducting similar kind of webinar because we have uh, many, I can say, health facilities wherein there is no any ABDM enabled application, but we are targeting to have each and every pharmacy or the lab as well to have an ABDM enabled solution. So with this, we just want everyone to share the feedback and suggestions, that how, if you have any innovation that which you want to share it with us, you can share it. Along with me, Dr. Amardeep is there on this call. I'll request Dr. Amardeep to please share the feedback link in this chat, webinar chat, so that everyone can get connect with us. And of course, our team will be in touch with you if you share any feedback with us, and we evaluate it and we will surely get back to you. So, in short, after this webinar, in case you want to connect with us, uh, at last, I would like to mention one thing, that yes, eSushrut Clinic has been developed by CDAC CDAC, that is Center for Development of Advanced Computing, which was one of the first supercomputer being developed by CDAC. So it's an, CDAC comes under Ministry of Health and family welfare, along with the MITI, I can say, Ministry of Electronic Information Technology. So they are with CDAC being supported for development of the entire issue clinic product. So the trust of sharing of the data, that is the concern that has been well taken care when we have when we are supported with the CDAC, right? So this is whole about my understanding. So I'll request everyone and Dr. Mridula to further take up for the Q&A session. And yes, along with me, Dr. Amardeep is also there with us, related to the Q&A. You have related to ABDM, eSushrut, or CDSS, that we can easily take up. Thank you so much. And yes, Dr. Mudla, we are here for next 30 minutes only for Q&A, and any question related to how you can get in touch with us.
Right. Thank you so much, ma'am, for this insightful session. So the session is open for Q&A now. People can raise their hands, and then I'll take a name. Then you can unmute and ask your question. So if anybody has a question, please go ahead. Yes, Doctor.
Yeah, so I'm Dr. Utsav, actually. So I was actually asking, so the CDSS that is going to be implemented within the eSushrut clinic, is it like AI enabled or LLM based, or is it like a knowledge driven, rule based kind of algorithms? So
See,
how much is the trust we can have on that CDSS actually? Is there chance of hallucinations like LLMs do?
no, no, it's nothing like that. First of all, in terms of trust of sharing of the data and all, it's completely an ABDM compliant solution, wherein we have certain set of milestone that every HMIS solution need to be compliant with, wherein the protocols of I can say the security audit in terms of sharing of the data has been well taken care of. And second, when you say it's a kind of large LML or AI kind of thing, currently this is a basic product which has come into the market. And yes, the next targeting point, we are targeting to have another level of having the LLM kind of setup, which will be used for giving any future production predictions, to the doctors for diagnosis or prevent any pandemic kind of.
Understood. Thank you.
Right. Ma'am, if I may ask a follow-up question on this. Like Dr. So said, what is the accuracy of the CDSS that you have observed? And is there any provision of liability where the suggestions by the CDSS, where does the liability lie?
Yeah, I would like to add here Dr. Amardeep, to
Yes,
who is leading this initiative.
yes. So
Yes.
very good morning to all. Thank you so much for joining this webinar. This is primarily for the eSushrut Live. Uh, we have integrated with the CDSS platform. I hope I'm audible to everyone. Okay, so this CDSS, we can talk more about which stakeholder is actually involved. So there is a National Health Authority and there is a separate team of AIMS who got involved in this. So how this initiative gets started? It actually started in 2011 and ended by the 2019. They had a set of research team. They had a research on the South Asia where uh, they implemented this solution in the more than 1,000 clinics in the India and the Pakistan. They have come up with the rule. They implemented their rule-based solution over there, and they have come up with the outcome of lowering down the 28% and the 32% of the micro and the macrovascular diseases, which can be associated with the diabetes, hypertension, and the dyslipidemia. This CDSS is primarily based on the three diseases, which is a diabetes, which is abnormal blood sugar, hypertension, abnormal BP, and the dyslipidemia can be associated as a abnormal lipid can be associated with the diabetes and the hypertension. So we have a certain outcome. We have a team who has done the research in the South Asia. Based on that, they come up with a solution as a CDSS, and we have integrated with the trusted partners who already got integrated with the ABDM platform. For the government side, we picked up CDAC as a eSushrut Lite and the NIC. Uh, this is a rule-based solution. What I think the previously the doctor has asked, this is a rule-based solution. This is not a AI-based solution. Doctor can easily get, if they are used to get if they're using it continuously, they can start predicting what kind of suggestion will be coming out through the CDSS module. It's a patient specific and it's a evidence based recommendation that we are getting. uh, it always give you the drug titration, if there is a need of increase or a decrease or a dose of drug, if there is any contraindication, any neurological sign which is associated with any of the condition, if the patient is already being on the medication. So this is a valuable product. This would be a asset for a doctor. Anyway, the doctor is entering the vitals and the sum of the basic values in the HMIs. If they're clicking on the CDSS recommendation, on the same time they will get the recommendation over the patient's health. The CDSS can also suggest you what kind of treatment can be taken up. The decision making will always be a doctor. Doctor can accept or decline whatever the suggestion we are getting from the CDSS module or CDSS tool. They can accept if they are thinking it is well aligned with the physical or the clinical condition of the patient. They can accept. If they accept, they can, whatever the suggestion is coming up through the CDSS, all the drug will be go on the prescription part. If they are not accept any recommendation, if they are thinking that something is not getting aligned with the patient's clinical condition or uh, uh, on the clinical remark, they can simply reject the recommendation and write the drug whatever they want. The most important thing from the CDSS perspective, we have only kept the drugs which is a most usual or most basic drugs which has to be available in any of the HMIS. For example, a bigunite. I think we have the audience of the doctors and the healthcare professionals. They truly understand the value of the doctor, the name of the value of the medicine, and the name of the class. So if we are getting a bigunide as a metformin, these are the basic drugs which has to be available in any of the HMI. So we have kept the basic drugs instead of the brand name value. So it would be very easier for the doctors uh, to get the recommendation by using the light HMIS. And one more benefit, if the doctor is a MBBS, a physician who has not been a specialized as a diabetologist or being a specialist to treat the hypertensive patient, still they can use this software, they can use this tool to treat the patient. I'm not saying they are going to capture the marketplace of what the diabetologist has made, but as a baseline treatment, as a conventional method of giving a treatment or giving a drug or giving a suggestion over it, they can take example, they can take help, they can take assistance from the CDSS tool. I hope I answered your question. But if you have any follow up question, please do ask. I'm happy to answer you over the CDSS part.
Yes, sir. Thank you so much for answering that well. Dr. Abhijit, you can go ahead with your question.
Hey, hi. My name is Abhijit, and I work for Oracle Cerna. This is really good, and thanks for sharing all these insights, Anita and Dr. Amar. I have a few questions, specifically when it relates to the data retrieval, the data storage part of it, right? Because it's a similar kind of an issue, and certain things which are also available, and challenges also available in other continents as well, apart from India. Uh, so my first question is, when it comes to data retrieval part, because it's a data exchange interoperability mechanism that would operate here, are we storing and are we looking at some sort of a central repository for kind of for a at a national level, wherein all these clinics, big and small, would store their data and exchange their data with? That's question number one. Uh, the second question I have is, again, specifically similar to what was discussed just some time back, uh, around the policies related to using the recommendations, the compliance and regulations. Are we looking, and is the government getting it enhanced and ensure that it's in place before actually this implementation and adoption of this gets started by the hospitals? Because once there is an adoption, once everybody starts using it, and if there is a policy change and compliance change, similar to HIPAA, GDPR, or whatever that you name it as, the adoption might slow down again, right? So I'm just trying to understand these two major uh, things, if I'm making adding relevance here.
Thanks, Abhijit, for raising a concerns related to data sharing and, in case of policy change there in future, then the adoption may be a concern. Yes, we do own your questions and, well said that, in case there is a policy level change for adoption, then there is a concern. Yes, coming back to your first question that, in terms of sharing the data, you say. So, see, first of all, the data sharing, I'll say it's 100% secure. The DPDP Act, which has come, 1 year back as a compliance part, but initially when ABDM ecosystem initiated its journey, the first point which was thought is that any data which is being created at the hospital or the lab, as a report form, will be stored with the respective hospital and the lab itself, right? And then in terms of that report or the prescription that has been created for any patient, we've been asked to share as well. Then the journey of, the transaction from one source to the another source, that is also very secure. How I am saying that is that there is no such central repository at ABDM ecosystem which stores the data of the
Hmm.
patient related to its
Hmm.
prescription or it is related to report or any kind of information, except the part that, we mentioned, our HFR and HPR is only the central repository that is here and the NHPR portal for storing the source of the truth related to the fact that the facility and the doctors are verified source. Rest, the patient journey and the hospital journey is stored at their respective ownership only. The ecosystem which you saw my initial few slides where, we showed plugs, right? I'll just get back to that slides once again. And here, this one, you can see here that, the private hospital generate any record just to exchange that information. ABDM ecosystem enables. There is no storing of the data in between, right? And
Correct.
the exchange of the information is also so much limited that we have an option that if a doctor asks a certain set of records for, specific dates, the duration and the time as well, that suppose if I am at an hospital under IPD going under certain treatment, and doctor needs last 1 month data related to its lab reports only, then it can tick those parameters, that is called hi types, that they can take on it and select that I need only the lab reports, I don't need rest of the health information, and only for 1 day, for 24 hours. That much security of asking the to the patient is also given to the doctor. And next, in case patient also have the complete ownership even after the request, if the patient want to share, then only they will share. So that kind of security and safety has been well taken care of, for in terms of data
Okay.
privacy and the security while doing the exchange of these transactions, right? So there is no such repository which is being taken between doing this transaction, right? And the second question which you asked, that in terms of policy level, and as I mentioned initially, it's completely volunteer, right? But yes, when we say volunteer, it's always the benefit to you which push you to go for an adoption, right? See, when we go to any doctor, with a simple example, I'll say, when I go to a doctor asks me, what is your history, why did this happen? So it's a history which speaks. And doctor sometimes thinks, maybe if suppose a 10-year child is speaking about his past history, and if I am speaking, the trust of the information sharing is different. But if the doctor says that, show me your prescription of the last 5 days based on which you're today here, so that will have
Mhm.
more trust. So considering these things, although we have adoption right now at a volunteer, but yes, the benefit itself will force you to be on part of this ecosystem. So in terms of policy and all, yes, there is, we nobody knows the future, but yes, we are focused for ABDM adoption in terms of the benefits that a provider will get and a citizen will get to better quality healthcare services.
Uh, Thank you so much. And just one very quick question.
Yes.
The recommendation layer that we spoke about, or Dr. Amar spoke about, right?
Yeah.
Wherein the diagnosis, based on the diagnosis, some sort of a recommendation plan and stuff like that. It sits on top of this middle layer, wherein after the exchange, based on which uh, there would there would be some sort of a recommendation that might be delivered to the doctor as a part of CDSS, right?
In terms of you are saying, what is uh, the exact question, if I understood it, the accuracy of the information that is being shared based on the
Uh,
vital sector.
no, I'm not talking about the accuracy. I'm
Yeah.
talking about where exactly that logic sits. Who owns that in terms of?
Yeah, Dr. Amar, can you just give a quick understanding on this question then?
Yeah. So I may pitch in to this query. So as a CDSS, as a part of the tool, we are not storing any data. We are just taking a data from the HMS. All the data has been captured by the HMS. It will be stored in the HIP. So
Mhm.
we are aligned with the federated architecture. We are not taking up any data. Instead of the weight, height, and the BMI value, we are not taking the patient's name. We are not capturing anything. We are not storing anything. We are just taking out from the HMIS, giving
No,
you a
no.
recommendation, and
Uh,
it will not stored.
Dr.
So,
Amar, the question is that the recommendation which is coming to the
mhm.
particular doctor, what is the source of the that recommendation, from where it is coming, and how
Okay,
does that work?
okay.
Right,
So
Abhijit, this is the
Yes,
question,
that's
right?
correct.
so I'll
Yeah.
tell
That's
you
correct.
the whole scenario and how it gets started. Patient definitely reaches to the hospital and meeting to a doctor, so that is a first checkpoint. So patient can check in that we can take an example of the diabetic patient. So diabetic patient arrives in the hospital or clinic for the consultation. The second point would be the second milestone or checkpoint would be the initial assessment would be done by the nurses, and they
Hmm.
can do it. They can keep it in a HMIS, like the what is the value, what is your age, what is your weight. They can request for access the previous test report like the HbA1c or whatever they had it before. Then if they are clicking on the CDSS analysis, now the CDSS will come into a play. Each and every information has been captured by the HMIS. Patient has checked in. Patient wants a consultation with the doctor. CDSS would start as analysis. The CDSS analysis the data to generate the diagnosis, the treatment plan, the lifestyle recommendation, patient drug interaction. Doctor can again review those recommendations. If they are okay with the recommendation, then the doctor can provide the final consultation and prescription to the patient. So this is, we can imagine how the doctor patient journey is actually happening around the CDSS module. CDSS as a set of data, we are just taking a data whatever it's being input within the HMIS. We are not storing, holding any data as a CDSS platform, as a
Okay.
CDSS module. I got your point, sir, because if somehow we are not continue with any of the HMIs, we wanted to be working as a standalone. What about the data that we have captured? On what basis we
Right.
have given the recommendation? So
See,
once we detached or once we go out from the HMIs, we will not take any data. All the data will be
Got it.
residing
So
on the
it's
HMIs.
right,
it's
right.
all transactional right now.
Correct.
Wonderful. Thank you.
Yes, yes. Adding to what Amardeep mentioned is that, see, Abhijit, the fact is like, uh, basically it works all on the open API kind of platform, wherein a vital set of vitals is being given to the CDSS, and those vitals in terms of API, that is the input API, which triggers to the another side of CDSS database, which is exactly based upon the entire search of large volume of data which has been taken from years, which
Mm-hmm.
Amardeep mentioned also in the beginning that it is a long research which has
Yeah.
been taken, and then this entire system has been developed. The input set of API is been triggered to the set, and then there is an output which comes from the CDSS, and that is being reflected on the HMIS, which is ABDM enabled only. This is how the entire ecosystem works,
Got
which you
it.
said is exactly a transaction, yes, but it depends upon the vital which is being entered at the nursing desk.
Sure. Thank you.
Right. Thank you so much for making it so clear. So, due to time constraints, I would request the next participants to ask one question each. Dr. Swati, you can go ahead.
Hi, everybody. Firstly, thank you for organizing such an insightful session, guys. So, I am Swati. I am the founder of Ampara, which is a health tech platform designed to help NRIs, like non resident Indians, stay connected to their parents' health and well being in India. So we want to strongly align with the ABDM standards. So I have a couple of questions, but I'll start with one and maybe email the rest of them. So my question is, so which health locker APIs or sandboxes are currently available for, early stage startups to experiment with?
If I understood your question correctly, you are asking that if you have an application, then what are the set of APIs which is being available that will enable you to be part of the ABDM ecosystem, right?
That's exactly right. Yes.
Fine, absolutely. So, Amardeep, would you like to add to this, or shall I go ahead?
No, I'll add to this.
Yes.
So, may I know the name of the person who has asked this question? Uh,
I'm Swati.
okay, so Dr. Swati, there's a set of process if you want to be a part of ABDM, if you want to part of this ecosystem. So there's a sandbox.abdm.gov.in. So there's a separate website.
Mhm.
Before that, Doctor, I'm sorry if I'm not taking a name correctly. Mridula, can we enable the chat so that we can share the
Yes, yes,
uh,
absolutely. I raised my hand for that only. If you enable both of us to for chat window, we'll share certain important links of ABDM, to know the people about how to onboard the ecosystem.
Yes, sure. I thought it was enabled. I'm sorry, I'll enable.
Okay.
no problem. So by the time it is getting enabled, we'll share the info. Okay, I think now it's being open for all. So in the meantime, I'll share the. Uh, just give me a minute. I'm sharing the link over it. Then we can continue the talk. Okay. Thanks. Thank you so much, Anita, for sharing the Google link account. Okay, so this is the link for the sandbox registration. So, Dr. Swati, if you are a tech partner, if you're the health tech startup,
Mhm.
I think the next point would be you want to become the ABDM enabled solution. You want to be under the ABDM ecosystem. The first point is you need to register yourself under the sandbox. So there is a simple one pager form where you can register yourself. You can express your intent to be the ABDM partner, and on what parameter you want to be a ABDM enabled solution, as a HIP, as a health information provider, as a health information user, as a government hospital, as a private one. So there's a simple form. You need to select those options, and your company's name, URL, email ID, and the email ID should be an active one, because whenever you are registering yourself or registered yourself, you will get a client ID and a secret, uh, which would be a benefit, which would be useful for you to get the response from the APIs. So there's a
Mhm.
certain
Okay.
process. Once you registered yourself, once you get the client ID and a secret, you can access the API which is available in the ABDM ecosystem. We'll give you the APIs. You can test it at your end. You will get the response from each and every API. Then on the
Okay.
UI part, there is a reference application, which is a ABHA portal, which is ABHA website. You can take a look and you can start designing on how the ABHA can be generated. I'm just giving you the link over it. Just give me a minute.
Sure.
Okay, so this is the link. So where you can find how you can build your solution in terms of the user experience. How you can start building on the solution, how you can capture the Aadhaar, how you can get the Aadhaar detail. So the most important point is you need to register yourself under the sandbox. Once you
Mm-hmm.
register,
Yep.
you will get the client ID and a secret from the National Health Authority. The NHA
Mm-hmm.
will review your form, review your intent to become a ABDM partner. Then they will give you the client ID and the secret, which is a kind of the basic things where you can get the access token from the gateway URL, and you can access the rest of the API. So there are three milestones, ma'am: M1, M2, and M3. So
Mm-hmm. Yep.
M1 is just creation verification of ABHA. M2 is getting a health data through your PHR app if the HIP is linking your health record, and M3 is if you want to see any past health record from any other facility, if the patient has
Okay.
visited any other facility as a HIU, if you want to see any of your past health record from the patient perspective, you can raise a consent, and then you would be able to see the patient's health record if the consent given by the patients.
Sure. Okay.
So these are the
Thank
basic
you.
things.
Yeah, thank you for that. I saw that Milestone 1 APIs are available. Do we have any timelines for Milestone 2 and 3?
So whenever you want to integrate it with the ABDM ecosystem, you cannot restrict yourself just to be a M1 compliant. You have to complete M1 and M2 all together. This is
Okay.
all up to
Okay.
you if you want to be M3, but M1, M2 is a mandatory, which is a baseline or a basic things that you need to achieve. Just a M1, we cannot give you the production key. You cannot go live. You have to come,
Okay.
because what is the purpose of creating ABHA? The purpose is you want to link your health record and you want your patient to view all the health record on the PHR app. If that is not happening, there is no need, or there is no benefit to just become a M1 compliant, which is a ABHA one.
No. So my question was, ideally,
Hello.
we'd like. Sorry. Hello.
Yeah, Swati, just go ahead.
Yeah, sorry. So my question was, ideally, we'd like to create the ABBA ID and also be able to, view their current information as well as their past medical history through the app that
Mhm.
we are building. What I'm saying is, on the website, while I was researching, I saw
Mhm.
that we had the sandbox environment links for Milestone 1,
Okay,
but I didn't see anything for milestone 2 and 3. So my question was, is that already built from the government and is that
it's
available
already built.
for apps like us to use it?
It's already built. You will
Okay.
find out whatever the link I have shared you. You can find out the
Mm,
documentation part on the left side. You will find out the M1,
sure.
M2, and M3 APIs. You can find out the PHR API, each and everything, whatever the services we are providing you, UHI, whatever. If you want to build, if you want to participate in any of the other services, all the APIs are the
Mm,
available. And there
okay.
is no as such timeline. We don't want you to be complete M1 in just a 15 days or a 10 days, but yes, this is all based on the support that we are giving you, and based on the effort that your development partners or developers will give you to become a ABDM enabled solution. So this would depend on, some part is dependent on you, some part is dependent on us. So the NHA is always be happy to support all the partner, but this is all dependent on how you are building your solution and how much time you want to build to complete your integration part. So there is no as such timeline, but some of the integrator have completed M1 in a 1 month, have completed their
Okay.
M2 in a 2 month or a 3 months. So that's all dependent on the effort given by the development team.
That's great. Thank you so much for answering. And finally, I just wanted to see if we can get a short consultation at your convenience, just to explore how early stage startups like ours can engage responsibly with ABDM.
If any consultation will be happening, that will definitely reach out to any of the partner who can bring you down and to do a consultation soon.
Okay, great. Thank you.
Thank you so
Yeah,
much.
Dr. Swati, we have a dedicated team for to support for integration of any HMIS or enable any HMIS provider to get it. I think so. You are part of it, and you do your registration on Sandbox. The team will automatically get in touch with you. Or on the other side, we have just published this Google link, and you can just put your email ID and the contact details so that I'll ask my team also to get in touch and give you a smooth pathway for your integration.
That'll be great. Thank you so much.
Yeah.
Right, thank you. So we are out of time, but we have a lot of questions. So if is it fine, Anita and Dr. Amar, if we extend for like 5-10 minutes more?
Yeah, we can take up for next 5 more minutes.
Mm.
We have another call at
Uh-huh.
12:30, so we have to
Mm.
be prepared for that. Nothing more than no concern other than that.
Right. Thank you so
I'll
much.
keep it short. Like, is the eSushrut for our clinic fully live? I tried to log in, but post the logging in phase, I'm unable to like move further, select any facilities or create a new facility also. Is it fully live or is it just dysfunctional for me?
Sorry, Mr. Ravi, your voice is not that clear, but whatever I understood is that you asked, is it live or not, right?
Yeah.
Yes, yes, of course. Onboarding has already started, and I mentioned in the beginning that approximately 100, around 100 practitioners have already registered themselves, and they are in process also that, and also few of them are already initiated their registration and prescription through HMIS
Okay.
Live. We have 100 plus prescription already been taken, and which was recently launched on 14th of August. I'll say the MOU was signed for this, and after that, a basic pilot launch has already been taken for this.
Okay. Okay. Okay, ma'am. Okay.
Right.
Yeah, hello.
Dr.
This is
Pramod.
Dr. Pramod here.
Yes.
Can I ask a
Yes,
question?
please. Yes, please. Go.
Okay. May I request you to please show that slide where you showed the flow, the patient flow or the other, or the workflow of how a patient gets registered, and then go on to how the ABA is created and so on. There was a slide you showed, right? May I request that slide to be shown again?
Yeah, sure. Wait a minute, I'll do that.
We have request others also to put
This
their
one, right?
This one, correct, correct.
Yes.
So a very important question here.
Yeah, please go ahead.
when yeah when we look at how this works, right, and
Yeah,
when the past records have to be pulled up,
yeah,
I think what this slide is showing is that the past records can only be pulled up from that patient's PHR. I don't think this is showing that it can be pulled up from another facility's records. Is this what I'm seeing here?
yes. So I think so
Correct.
you're talking about the fourth dot, right? During the consultation,
One,
doctor
two, three,
request
yes, four dot, where the
during the
previous health records.
Yes, during the consultation, doctor requests if she can see the previous health record digitally and raise a consent request for the same, which goes next to the dot that the patient accept the consent request and share his previous health records with the doctor. That is based on the PHR app of the patient, right? And the request has been raised from the HMIS that the doctor is using, right?
Yeah, my question is about this now.
Yes, I'll answer to
My
this.
question is, see, if a system is M3 certified,
Yeah,
then I should be able to ask these records to be pulled up with a given date and or whatever it is from
yeah,
another healthcare system or another
yeah,
HMIS. Correct?
yeah, yeah, yeah.
Is that already live? Is that working?
Yes, yes,
It's
absolutely. See. I'll answer this question. Don't worry. See, the first part, this consent grant session, that the left side screen which you mentioned, this is the PHR app of the patient, right? This PHR app will have all the records for any HMIS provider or the any consultation this patient has taken, whether it is from A, B, C, or D hospital. All the records will be linked to its ABHA ID, right? And that ABHA ID will have its linked records from whatever hospital the consultation has been taken. Whereas, if suppose A hospital is there, that is the consent has been raised, right? And it wants to view the B hospital records for this particular patient, then A can raise the consent request to patient first, that I want to view your B and C health records of the hospitals to diagnose your treatment. For that, the consent will be given by the patient to access the record of that HMIS provider of hospital B and C.
No, so then what happens? Agreed, the consent is given.
Yeah.
Then what are the next 2-3 steps? How does the HIU finally get the records? What are the steps happening after between that and getting the records?
Yes, why not? See, as I mentioned that, it is an M3 enabled, right? So both the system who is raising the request and who is accepting the request, both are ABDM enabled M3 milestone, right? It means they have M1 and M2 that created linked, and now the records are able to share between the providers, right? So when the request is being raised by a provider and asked by a provider to share those records, that basic linkage and the API integration has already been taken at the patient's level or the hospital level to share its records. Suppose if consent has been raised by an M3 enabled, right, and the hospital where the patient linkage has done the with the PHR app and don't have the M3 enablement, then sharing of the record with that respective hospital may not be possible. But if it is M3 and they are raising the request and accepting the both are M3 enabled, then automatically the APIs will work to do this transaction or
I mean,
of the
no,
record.
I do. Does it how automatically means the HIP's system will automatically send the records, or will they have to be a sort of okay given by the HIP's system? How does the
HI,
records then reach? And secondly, you're saying that the records will therefore not come through the ABDM network. It'll have to
yeah.
be sent through some email or something like that, correct?
No,
That's how it'll have to work.
no. It's nothing like email or anything like that. Dr. Amardeep, would you like to add on this, the way we do for national programs?
Yes, please. So,
Yeah.
Mr. Pramodji, just wanted to take you ahead on the web page. You can imagine yourself, you are using a screen. You are a doctor. Amardeep, as a patient, came to you. Now, Pramodji wanted to see my past record because I had visited in AIMS Delhi also before. Sir, you have a tab which there will be a mention as raise a consent. You can click on that. You can mention about few things about my ABHA details. What is the reason of taking a what is the reason of raising a consent? What kind of HI types you want to see? Whether you want to see my diagnostic report, whether you want to see my prescription, whether you want to see my immunization record, and what is the timeline of to see my health record till 12, 15, 14 September you want to see, and there should be a range of data record because you are having a consultation with me. So you want to see my health record from the range of 1st August to 31st of August. And if any time, if I'm giving you access to view my health record, it should be remain on your screen till 12:15. Have you understood this process, sir? Till
This
this
much I
point.
have understood. As
Okay.
far as what the theory is saying, yes, I've understood.
Okay, no problem, sir. Now I'm taking you ahead. You have clicked on the raised consent. The consent will be raised, and it all the information will go to the all the HIPs wherever I have visited during that time period. So I have only visited to the AIMS if you because you have set a timeline from 1st August to the 31st August. AIMS is ready to give you the information, but there will be a consent has to be given from my end. So there will be a consent coming up on my PHR app. If I'm granting you a consent, so there is a mechanism granting and decline of the consent request. If I'm declining my the consent request, you won't be able to access my health record, and you will have an option on your HIU application as declined from the patient. if I'm granting you a consent, you would be able to see all my health record and whatever the HI type you have selected.
One sec. Just hold on there, Amardeep.
Please.
How will I, at that moment, how will I see it unless the records are sent across to my system?
Okay.
How am I seeing those records? Is it being sent to my system, which has an as an HIU? And if it is being sent, is it being sent over the ABDM network?
Okay. So, sir, we have discussed about how you have raised the consent and how the consent will be coming up on my PHR's app. We have
Consent is all
understood this.
done. I agree.
Okay.
Consent goes back to AIMS. AIMS has received this saying yes, Pramod or whatever it is has consented for these records to be sent to him. Now, what does the AIMS system do? And secondly, how does the records reach the person who has asked for it? That's my question.
So we have discussed on the two parts, first and second. Now the third part will come. If I'm giving you a consent, your health record will transfer from AIMS to your system. Within your system, because HMIs has raised this consent to the another HMIs wherever the HIP I have visited on the specific dates. If you have received the confirmed consent, a granted consent, then the record will be visible on your screen as a PDF format. There will be a tab, sir, view records. If you're clicking on the view records, those record will be view on your screen. You cannot take a screenshot of your screen. You cannot take a screenshot from the system. You cannot download those system. The only thing you can do is you can view my health record because it has been come up on your screen. It has been come up on your HMI system. So the view option will be available for you. Similarly, just giving you an update over the eSushrut clinic, you cannot take a screenshot. That functionality is already being built on the eSushrut Lite. You cannot take a screenshot of a health record if any health record is coming up from the M3 milestone. Because you are raising a consent, sir.
Got it.
And I'm granting it.
So therefore, you're saying the sending across of the record firstly by AIMS is automated. There is nothing that the AIMS system has to do if it's already M3 compliant. And secondly, also you're saying that the receiving it and seeing it is also automated, right?
Correct. But I am the owner of my app. Yes, sir.
And the records are coming over the ABDM network. Is the records coming over the ABDM network or through some external network? Is the transport of the record of this view coming over the ABDM network or through some external network?
So this would be go on the ABDM network. So there is a interoperability. So there is a federated architecture. Federated architecture means it is residing in AIMS only, sir. If I'm giving you just an option to view my health record, it doesn't mean I'm allowing you to store my health record. So this is a federated architecture. Interoperability means if you want to seek my health record, I am allowing you to see my health record. I am the owner of my application. I'm giving a consent of my health record. You just be able to view my health record. You won't be able to store my health record, and it will be revolving around the ABDM network only. If you're outside the ABDM network, neither the M1 will work, neither the M2 will work, neither the M3 will work. You won't be able to see my health record. Anyway, you have to ask me to bring down my physical copy of my health records.
Okay, fine. So this is like, therefore the record is still residing in the AIMS network, and I've been giving a view to it. This is like a DICOM viewer, somewhat like a DICOM viewer.
This is the classic example of the federated architecture. It will be residing wherever it is being created, sir.
No, that's fine. I'm watching the viewing will be something like that. How a DICOM viewer shows you a image or whatever.
You can take example of DICOM. You can take example of DICOM, but DICOM is a different thing.
Correct. I'm just saying parallelly, the concept is that it is still residing in the AIMS server, and I'm looking at it from my system into the AIMS server and looking at the record. That's what I understand. Is that how it is?
So you're not looking at AIMS server. You are just looking out the data which the AIMS has sent you based on my consent. You are not.
So there is a sending of information. A PDF has been sent across.
Correct.
Okay. All right. Thank you.
Thank you. Thanks. So one more, Dr. Mudra, one more update. I think we have given the editing right for all the partners. They can enter all the details over it, over the Google Drive link which the Anita has shared on. So we just want a small information over it, the name, the designation. Few have started filling up out. If you have any suggestion or innovation solution that can help the eClinical Sushrut Lite, I think the Anita can add on a much better way. Anita, would you like to add on the concept of this Google Drive link?
Yes. Actually, the in the beginning, the first chat link which we have shared is that only that we wanted here through THC, platform, that we want others to come up to us and such share their insights if they have any suggestions or innovation which helpful for issue clinic, and it will help to serve the community better. So we would like to have further discussion with them and enable them to come in touch with NHA as well based on the evaluations. So of course our team is here. As I mentioned, there is a team dedicated for only for private adoption, and we would like to connect with those people. Yeah, Mr. Pramod. Last question. I think there should be. We have a limited 12:30 timings. Yeah, Mr. Pramod,
Oh,
you.
sorry. I need to bring my hand down. My
Okay.
question. Okay.
Okay. Fine.
Right.
Okay. Over to you, Dr. Mridula.
Yes, thank you so much, Anita and Dr. Amar, for taking this session and answering the questions so patiently. So, if there are any further questions, the Health Tech Collective can also facilitate the communication. Dr. Anita has obviously shared the links to facilitate the communication. And I thank everyone else for joining and participating in this discussion. I think we can. There seems.
Guys, uh, I have one question.
Um,
See,
Anita, would you like to pick it up right now, or shall we?
Okay, sure. As asked, but I think so. I'll have limited 2 minutes. I'll quickly try to answer.
Please
Yeah,
go
please
ahead.
go ahead.
what is mean by CDSS? Means that you said like CDSS platform like that. So that's why I just asking.
Yeah, CDS is basically a clinical decision support system which is developed by AIMS Delhi, and that is being given free of cost to all the ABDM enabled HMIS providers, which helps the clinics, basic practitioners to give certain recommendation directly from the AIMS on some of the basic vitals that is being entered, right? Related to hypertension, diabetes, and a few things. So these three recommendation are something which supports the doctors, to have a opinion kind of directly from AIMS. That is
Okay.
the basis.
Right, thank you. I think we can close the session now. Thank you so much for being here.
Okay.
Yeah. Thank you so much.
Thank you.